All right. Hi, everyone. Thank you very much for joining this week's seminar. We're going to start now because we have a lot to cover. But yeah, so today's seminar will be partly on surgical and ethical differences between adult and pediatric neurosurgery, which is quite a niche topic. And it would be really, really helpful for you to, it'd be really informative because you'll be able to see the different types of surgical techniques that are used based on the type of patient you get. And so this would be really, really important. And then we also have Neha, who's going to be talking about the well-being segment, and it will be on a topic. So yeah, let's I'll hand over to Shi Meligo, and she's going to take over for like the first 10 slides, and then we'll have the rest. Sorry.
Um, okay, yeah, so today we'll be talking about anatomical and physiological differences between the pediatric brains and adult brains and the implications that these differences create. So, key anatomical differences. Children have a higher proportion of gray matter, which are also known as cell bodies, and this gray matter peaks in volume in late childhood around the age of 10 to 14, but this depends on the sex of the child and the brain region, after which it decreases throughout adolescence. In the pediatric brain has a higher water content and it is softer and more pliable or flexible than the adult brain, and a 2-year-old's brain has roughly 50% more synapses, or which are like connections between nerve cells, than an adult brain. Adults have significantly more white matter, and the white matter volume increases steadily until mid to late adolescence, and it enhances the speed and synchrony of signals. The adult brain is roughly 3 to 4 times stiffer than the pediatric brain. Differences in regional development and connectivity. In adults, the basal ganglia are more developed, and the basal ganglia helps with motor control, procedural learning, habit formation, and cognitive and emotional functions. Children's basal ganglia are still developing, and they can affect the ability to control movements, make decisions, and manage impulses. Research has shown that children with ADHD tend to have smaller basal ganglia volumes, and these differences in basal ganglia structure and function are closely linked to the ADHD symptoms like hyperactivity, impulsivity, and poor motivation. In children, the PFC or prefrontal cortex is still developing and can lead to impulsive behavior and difficulty in planning and decision making. However, in adults, the prefrontal cortex has matured and allows for better self regulation, impulse control, and the ability to make sound decisions. Children rely more on subcortical regions like basal ganglia for processing, whereas adults show more specialized, distributed activity in the cerebral cortex. The prefrontal cortex is responsible for impulse control and decision making, and it is one of the last parts of the brain to fully mature, and you can until the mid-20s for it to mature. At birth, the brain is about 2% of the adult brain, and it reaches approximately 90 to 95% of its peak growth by the age of 6. Key physiological differences. Per gram of tissue, a child's brain consumes roughly twice as much glucose as an adult's. While the adult brain uses 20 to 25% of the body's total glucose, an infant's brain can consume more than 40% of the body's basal metabolic rate to facilitate rapid development and learning. Cerebral blood flow, which is the rate of blood delivery to the brain, is lowest at birth but increases rapidly, peaking between ages 3 and 7. At this peak, global cerebral perfusion, which is the total blood flow throughout the entire brain, is roughly 2.5 to 2.7 times higher than in adults. In children under 4, nearly 45% of total cardiac output is directed to the brain, compared to only about 15% in adults. Clinical implications of these differences between the pediatric and adult brains. Clinical implications between the differences. Oh, okay. Clinical implications between the differences between the pediatric and the adult brain. 1. Because a child's brain is softer and has higher water content, it is more prone to diffuse external injury rather than the localized bruising, which is common in adults. Diffuse external injury is a severe form of traumatic brain injury, which is characterized by the widespread damage to the brain's white matter, often resulting from the shearing or cutting of axons due to rapid acceleration or deceleration forces. Children are vulnerable to rapid catastrophic brain swelling following even a minor second injury before a first concussion has healed, and this risk diminishes significantly in adulthood. A normal intracranial pressure for an adult might be dangerously high for an infant, and clinicians must use age-specific nomograms to avoid misdiagnosing brain swelling. An injury during a critical window of development or an important phase of development can be more devastating than an adult injury. A child may seem fine initially, but then grow into a deficit, struggling years later when complex logical or social skills are expected to emerge. So this image basically describes diffuse or external injury. So the child suffers trauma to the head, and then there is a rapid acceleration or deceleration of forces in the brain, and the white matter suffers damage because the axons have been sheared. Common neurological conditions in adults and pediatrics. Key differences in neurological conditions can differ significantly between adults and pediatric patients. In adults, conditions are often linked to degeneration and external risk factors, and in children, conditions are commonly related to brain development or genetic factors. Adult neurological conditions are commonly associated with aging, lifestyle, and vascular risk factors. Common examples include stroke, brain tumors, and neurodegenerative disorders such as Alzheimer's and Parkinson's disease. These conditions are often progressive and may result in long-term disability with limited potential for full recovery. This image shows the differences between a normal brain and the brain of someone that has Alzheimer's. Common neurological conditions in pediatrics are often related to brain development, genetic factors, or birth-related injury. Common examples include cerebral palsy, epilepsy, congenital malformations, and pediatric brain tumors. These conditions can affect development, learning, and long-term quality of life. Clinical implications of age differences. Age significantly influences how neurological conditions are diagnosed and managed. In adults, treatment often focuses on slowing disease progression and maintaining independence. However, in pediatric patients, treatment must consider brain development and long-term outcomes because decisions in children have long life consequences and require careful planning. Uh,
Okay, so now we're going to move on to differences in surgical techniques of pediatric and adult neurosurgery. Okay, so in terms of pediatric neurosurgery, it mostly focuses on congenital development or genetic conditions in the developing brain. And when it comes to adult neurosurgery, it mainly focuses on acquired diseases like tumors, traumas, and etc. Usually due to wear and tear. So essentially pediatric neurosurgery is more about dealing with genetic malformations within the brain, whereas in adult neurosurgery is more of fixing the acquired issues that they gain later on in life. So, in terms of neurophysiological recovery, neurophysiological recovery may continue for several years with improvements noted in cognitive speed, memory, and visual skills. Although there are often poorer outcomes associated with severe brain injuries and secondary complications. However, despite these risks, children and adolescents, so young adults, often have a better long-term outcomes than adults following neurosurgery. However, intensive follow-up is necessary to address emerging behavioral or academic issues um, years after the injury. So, in terms of neuroplasticity, so neuroplasticity is the ability of the brain's neural networks to change through growth and reorganizations in response to various stimuli, experiences, and even injuries during childhood. So, essentially, in shorter words, is basically how the brain is able to adapt and kind of like take in a change. And essentially, children have a greater neuroplasticity than adults. And so, because of this, children are able to recover much better, and they're able to have much better than adults and have minimized long term development challenges. This also allows neurosurgeons to treat a wider range of neurological conditions in children with better outcomes. Next, please. Okay, now we're going to move on to ethical differences in pediatric and adult neurosurgery, specifically focusing on autonomy and consent. Okay, so in terms of adult autonomy and consent, so the principle of anatomy, not anatomy, autonomy, as we already know, is the legal and moral right of a patient to make their own decisions about their body. So essentially, their right to be able to choose their healthcare that they're receiving. So if an adult is found to have capacity, which is really important, um, they have the right to choose for themselves, and that whatever decision that they make is the final word when it comes to their treatment or what their healthcare essentially. And this means that their decisions cannot be changed or ignored by doctors or family members, and even the person's choice, even if the person's choice may seem wrong, the doctors or healthcare professionals or anyone in their family cannot override that. And so making sure that the patients have a like a good understanding on their care, so that they can have like so they can do choose the best possible decision is really important. And by law, all adults are presumed to have the capacity to make their own medical decisions, and for consent to be legal it must be informed. So, given all the risks, so all the positives, all the negatives, all the side effects, and any possible outcomes that the surgery or the procedure could occur, it has to be voluntary. So, no one, including healthcare professionals or family members, should be pressuring the patient to make a decision, and the person has to have the capacity to weigh all that information. So they need to essentially be able to retain all that information, make a good informed decision, and make the best possible decision that will affect them in the best way possible. So, a person with capacity has the right to say no to any care. This includes refusing life saving treatment, as their right to choose is more important than the doctor's duty to save them. And consent is a direct process between the doctor and the patient, and doctors cannot discuss treatment or consent with a patient's family member without the patient's explicit permission. So, in terms of pediatric consent and autonomy, children are seen as having emergent autonomy rather than full and independent autonomy. And their ability to choose grows as they get older. And that's because children often lack full capacity. So, parents or guardians provide the consent, and this is a duty to act in the child's best interests and not um the right not a right to own the child. So that basically means that the parents are supposed to essentially choose the best outcome possible for their children to allow them to have a better quality of life instead of choosing based on the fact that that's their children, if that makes sense. So even when patients give their legal consent, doctors should still involve the child, and getting the child to agree with the treatment respects them as a person, and even if they aren't able to make the final, even if they aren't the final decision maker. So in pediatrics, the main goal is to keep the child safe and healthy, and this ensures that they survive to make their own autonomous choices once they reach adulthood. Unlike the way other relationships work when it comes to consent, pediatric consent involves the parents, the doctor, and the child. So there's a few debates when it comes to ethics in pediatric cases, and the first one being quality of life. So is a decision that the parents that is a decision that the parents are making, will it impact their children's life for the better or for the worse? And operating on infants as well who cannot express their preferences. So that also does tie in with the fact that the parents might have to make the most informed decision, the most best informed decision for their child at that moment to allow them to be safe and to be healthy. We also have experimental procedures. So essentially, it's not really ethical to be carrying out procedures that aren't really that haven't been done before on infants or children. So that's also a debate. And we also have long-term unknown outcomes. So the procedure that the child is going to be having, how is it going to affect their quality of life later on the years? That's also something that's really important to keep in mind. Okay, so when it comes to transition from pediatrics to adulthood, so a child under 16 can actually make their own decisions and they have consent if they're assessed to have enough maturity and understanding of the specific treatment. And a competent adult's refusal is final, but the child's refusal of life-saving care can be overridden by parents or court. And also, it's really important to note that when it comes to pediatric patients as well, the the parent's decision can also be overridden by if the healthcare professionals do think that the decision that their parents are making on their children's healthcare is not for the best of their interest, then they can go to court and override that as well. So it goes both ways, not just with the um, children under 16. So with a child refusal is often ignored to save them for later. And this ethical argument is that a child's current choice shouldn't stop them from having a future. So at 16, young people are presumed to have a they have capacity to consent, just like adults. However, they're still minors. So they have to have a mix of adult rights and child protections, and that's known as Gaelic competence. So essentially, healthcare professionals would just have like a series of questions, just test that young adults to see if they do have that capacity to make informed decisions about their health. And then overall, adult health ethics focuses on the right to choose, while pediatric ethics focus on the right to be protected until the capacity is fully developed. So we have a few risks when it comes to pediatric case and adult cases. So when it comes to neurosurgery on children, so it could have detrimental impacts on their schooling, so how they mix, how they learn, and how they behave in school. Also cognitive development, which is their behavior, and their ability to learn, read, write, things like that. We also have identity formation, which can also closely tie in with like mental health and stuff. And we also have family, so how they may like be able to mix in with their family or like grow a family one day. We also have neurosurgery. So neurosurgery in adults can also have a detrimental impact on their employment. So neurological conditions or neurosurgery could could stopped could stop the ability of a few adults from going to work, and that could have detrimental impact on their finances and stuff if they don't have any other like didn't have any other support. So that's something that I can impact. We also have independence, so they may not be able to do things by themselves. And then we also have pre-existing comorbidities. So that's essentially other diseases or other conditions that the adult may have prior to the neurosurgeries. For example, hypertension, high blood pressure, and diabetes and things like that. So now we're going to move on to emerging issues and innovation in pediatric and adult neurosurgery. So with the role of AI in pediatric neurosurgery. So AI can have a big role when it comes to assisting in pediatric neurosurgery, such as creating 3D models and simulations, providing intraoperative feedback to assist with precise tumor localization and enhanced dexterity. So essentially, these three ways in which we can use AI are really important because it allows precision, it makes these surgeries less invasive, and it also, with the 3D models, it also allows the surgeons to maybe prior to the surgery to kind of see what's going on within the child's brain, and then be able to kind of like form a like a this like a plan on how to tackle the disease within the brain, which is really helpful. And when approaching this use of AI in pediatric surgery, neurosurgery, it is a matter of extreme caution, and it should be thoroughly consulted and regulated throughout its use in any case. So, in terms of genomic profiling and personalized medicine in pediatrics, so genomic profiling in pediatrics is the use of using advanced molecular sequencing to analyze a patient's genetic profile. And this can be used to diagnose rare diseases and personalized treatment plans. And examples include pediatric oncology, where the genomic profiling patients are matched with targeted trial-based therapies, and it also can be used to understand underlying genetic conditions. Genetic causes in children with development complications or undiagnosed syndromes. It can also be used in pharmacogenetics, where genomic sequencing data is used to identify genomic variants that affect drug response. So basically, genomic profiling is basically the use of science to provide the best personalized care for patients, essentially. So in terms of DBS in adolescents, so we have basically DBS stands for deep brain stimulation, and that involves the surgical insertion of electrodes in the brain, as you can see on the image on the right, and it's connected to a battery pack placed under the skin in the chest or the abdomen. And the battery pack essentially delivers an electrical current directly to areas within the brain. The primary use of DBS in adolescents is for severe treatment-resistant movement disorders such as dystonia, which is a movement disorder characterized by involuntary muscle contractions that use twisting and repetitive movements or abdominal postures, and epilepsy, which is seizures. DBS has the potential to hold many benefits, including improvements in motor function and reduction of spasms, but more research has to be done behind understanding the long-term effects of DBS on developing brains and potential side effects like personality changes. Now I'm gonna hand over to Serena, who's going to do the interactive quiz.
All right, thank you very much for that. Now I'm gonna do an interactive quiz. So that requires you guys to answer the questions on the chat, which we have been doing for the past couple of weeks. So yeah, we'll start with the first question. A 6-month-old infant presents with hydrocephalus requiring a VP shunt. I wouldn't worry too much about what this is. It's just an operation. What is a key long-term surgical consideration? Is it A, the shunt will likely last for life without revision? B, the child may need multiple shunt revisions over time. C, hydrocephalus always resolves spontaneously. And B, plasticity eliminates complication risk. So I'll give you about like 30 seconds to answer this question. Some hints I can give you is that obviously plasticity, as we've talked about previously, is higher in infants. So then this can help with like kind of helping them recover faster from certain conditions, but that wouldn't really eliminate complication risk. I might have just given up an answer, but yeah, we'll do with that. Okay, so a lot of people have put B, and that is right. So the child will need multiple shunt revisions over time, and this will have an impact on their quality of life after the procedure, because they'll have to kind of miss school for like appointments, or it might really have an impact on their mental health, because they would be like, oh, why do I have to go to the hospital all the time? My peers don't have to, so that could have an impact um, on that, especially in terms of the ethics side. And yeah, so obviously multiple shunt revisions could also have an impact on, it could increase the risk of infections or other complications that could arise. So that is also something that you could talk about in terms of the surgical consideration of this scenario. Okay, question two. A 45-year-old with a brain tumor understands risks and consents to surgery. What ethical principle is most central? So is it A, beneficence, B, justice, C, autonomy, or D, non-maleficence? I'll give you about 30 seconds. Yes, absolutely. It is C, and I've seen a lot of C's in the chat, which is great. We are also going to do a medical ethics pillar seminar after this neurosurgical series, because it was suggested by a lot of you. So we will definitely take that into consideration. And the reason why it is autonomy is because we previously discussed that autonomy is the right, an ethical right for the patient to decide what happens, and decides what happens with them in the hospital. And so in this given scenario, a 45-year-old with a brain tumor understands risks and consents to surgery. So I mean, she or he definitely already have capacity, because they understand the risks that come with the surgery, and then they also consent to the surgery, which means that they meet both requirements for them to consent to the surgery, and therefore this is C. All right, now three, why might ethical thresholds be considered higher in pediatric neurosurgery? So again, this was discussed. This is more of like a active recall type of question. So A, children feel less pain. B, outcomes affect the entire lifespan. C, surgery is easier technically. And D, parents always agree. Yes, B is correct, because obviously a pediatric patient will have their whole life ahead of them. So their outcomes need to be very, very like carefully considered, more so than an adult neurosurgery, like a neurosurgery. Like obviously they also have a life, like a longer life, but pediatric neurosurgery, they tend to live longer because of the neuroplasticity, and they tend to have better outcomes as well, because of the fact that pediatric brains have higher neuroplasticity. So they're more likely to survive. And so neurosurgeons especially prioritize making sure that they don't have any complications or any disadvantages to the surgery. And that's why it's very carefully planned and sought after. Okay. A 2-year-old A 2-year-old requires emergency surgery. Parents refuse treatment on non-medical grounds. So is it A, surgeries automatically cancelled because the parent said no to the treatment? B, the child decides. C, court intervention may be sought. Or D, the surgeon proceeds without question because they have the highest medical judgment and they know what's right for the patient. So I'll give you about 30 seconds as well. Okay, yes, everyone has said C, and that's correct. Even though the surgeon may have what's right for the patient in the best interest for the patient, because of their medical knowledge that they have, the parents are what kind of consent in behalf of the patient, because obviously the patient's 2 years old. They definitely don't have capacity to decide what is right for them. And so the conflict between the surgeon and parents, it needs to be addressed in a court. And it happens with a lot of cases in the NHS, actually. All right, sorry, 5. Which statement best captures the ethical difference between adult and pediatric neurosurgery? So is it A, adult surgery focuses on cure, pediatric surgery does not. B, adult ethics prioritize autonomy and pediatric ethics prioritize best interest. Or C, pediatric surgery is always more successful. D, there are no meaningful differences. Yes, you would be correct to say B, because adult ethics, most adults are presumed to have capacity, whereas for pediatric patients below the age of 16, they don't have the capacity they need to kind of have autonomy. So obviously we discussed a phrase called emerging autonomy. So that means that as a pediatric patient grows older, they tend to have more capacity because they understand the situation better. And so they have increased like ability to consent to certain things that happen. And that's why we have the law called Gillick's competence, which is technically used for like the contraceptive side of things, but it can also be implemented into like these type of cases as well. So yeah, it is definitely B. Pediatric ethics prioritize the best interest for the pediatric patient. All right, so that's all that we have for this presentation. Now I'll hand over to Neha to talk about emotional regulation and executive function in like surgical fields. So she'll be sharing her part of the presentation.
In medicine and especially surgery, knowledge alone isn't enough. Performance depends on whether your brain can access that knowledge under pressure. Today, I want to talk about how emotional regulation protects executive function in high-stake environments. High-stakes environments are situations where outcomes matter, time is limited, and performance is being judged, often simultaneously. These environments start before medical school. Aspiring medics already experience repeated high-stakes performance demands, whether that be for exams or interviews or application pressure, and your identity being tied to performance. Most performance breakdowns aren't due to the lack of knowledge. They are due to the loss of cognitive control under stress. This is why when you are stressed in high-stakes environments, you tend to experience freezing, a blank mind, overthinking, or making impulsive mistakes. Executive function refers to the mental process that allows us to plan, prioritize, inhibit impulses, and adapt when things change. Executive function underpins safe medical practice from exams to operating theatres. It is important for clinical reasoning, decision making, error prevention, and multitasking safely. When your brain is under stress, your threat response is activated, reducing effective control and narrowing your attention. The brain prioritizes survival, and this is useful in danger, but problematic in exams, interviews, and surgery. Stress does not just make you feel anxious, it actively reduces the brain's ability to reason and adapt, leading to reduced working memory, rigid thinking, poor inhibition, and slower decision making. High-stakes medical environments naturally increase cognitive load, emotional dysregulation, amplifying this further. This is why emotional regulation is important, as it preserves execution function, improves decision quality, and reduces error risks. Now I'm going to go through a couple of evidence-based regulation strategies. When we are under pressure, our breathing becomes fast and shallow, which signals threat to the brain. This keeps the stress response active and further suppresses executive function. Controlled breathing works by directly influencing the autonomic nervous system. Slowing the breath increases parasympathetic activity, which reduces heart rate and dampens the stress response. What's important here is speed. This is one of the fastest ways to intervene when you notice stress rising. You do not need to feel calm, you just need to reduce physiological arousal enough for the prefrontal cortex to essentially come back online. A simple example is slowing the exhale relative to the inhale. So, for example, you could inhale for 4 seconds and then exhale for 6. Even 1 or 2 minutes can noticeably improve cognitive clarity. Under stress, attention becomes fragmented. The brain scans for threats, which pulls cognitive resources away from the task. Attentional control means deliberately choosing what to focus on and excluding everything else. This reduces extraneous cognitive load and preserves working memory. In practical terms, this might mean focusing on a single question stem in an exam, one step of a procedure, or one clear priority during an interview. By narrowing attention, you reduce the number of competing inputs the brain has to process. This improves decision-making speed and accuracy. Importantly, this is not avoidance. It's strategic narrowing of focus to maintain executive function when cognitive capacity is limited. Cognitive reappraisal is about changing how the brain interprets a situation, not by denying the stakes, but by reframing what stress response means. When the brain categorizes a situation as a threat, stress impairs executive function. When it's categorized as a challenge, stress can actually support performance. For example, interpreting physiological arousal as my body preparing to perform rather than I'm about to fail changes how the brain allocates resources. This doesn't remove stress, it changes its impact. Executive function is better preserved, working memory improves, and thinking becomes more flexible. Reappraisal is particularly useful in situations you can't control, like exams or interviews or emergencies. Aspiring medics are especially vulnerable because of perfectionism, comparison culture, fear of failure, and identity pressure. When performance becomes tied to identity, emotional responses intensify, making regulation even more important. Repeated dysregulation over time impacts learning, well-being, and career sustainability. This is why you need to reframe emotional regulation and not see it as a weakness or optional, but as a core professional skill. These skills can be developed early, and doing so gives you a significant performance advantage. If we want to train to be excellent doctors and surgeons, we need to train our brains to function when it matters most. Thank you.
Thank you very much, Neha, for that part of the presentation. This is a very, very prevalent issue as well, because obviously all of us, we're doing exams, we're going to go into medical school and obviously pursue surgery for some of us. And so this is really, really important to kind of build as a habit from now. And yeah, so it is something to consider. I'm going to send off the attendance form in the chat. Please make sure to fill it if you're interested in getting the certificate for the neurosurgery seminars. We have 3 left. So yeah, I hope you guys are enjoying this and you're actually finding it informative. Please leave some suggestions if you have any in the attendance form. We do look at them and we make sure that we act on the feedback. And yeah, that is all we have for today. It will also be an early end, which is nice. And yeah, thank you very much for joining.